Hello and welcome back to the Deep Dive. This is where we take the source material you provide and, well, we really dig into it, pulling out the critical knowledge, the insights, everything you need to be the most informed person in the room without you having to wade through dense documents yourself. I'm your host, and I'm really looking forward to this one. You've given us a great set of sources on a really critical, complex area, managing vascular graft and endograft infections. Our mission today is guided by the 2020 European Society for Vascular Surgery Clinical Practice Guidelines. We're aiming for a thorough, an unabridged breakdown, specifically for specialist clinicians like you. Think of it as your shortcut to mastering these guidelines, getting straight to the essential information for diagnosis, prevention, and treatment.
Yes, it's definitely a complication no vascular specialist wants to face. But when it happens, it needs fast, precise, multidisciplinary management. And these guidelines, they represent a really significant step, consolidating specialist consensus for the first time in this kind of format from leading societies.
Absolutely. And, before we get into the nitty-gritty, it feels important to acknowledge the people behind these guidelines. The source includes a tribute to Professor Dr. Omer Tiebken. He was on the writing committee, but sadly passed away during its development.
That's right. Professor Tiebken was a highly appreciated colleague, a real pioneer in regenerative medicine, tissue engineering, and vascular surgery. His involvement just underscores the dedication that went into this document. It really highlights the collaborative effort needed for such tough clinical problems.
A fitting tribute indeed. Okay, let's unpack this. Our roadmap for today. We'll kick off with the why and how of the guidelines, their purpose, methodology, how evidence was graded. Then we'll dive into definition and diagnosis classifications, microbiology, imaging, all crucial stuff. We'll then shift gears to prevention, followed by the general principles of treatment, the MDT role, antimicrobial therapy. The core treatment discussion will break down strategies by location because, as you know, location really matters. Supraortic trunks, thoracic thoracoabdominal, abdominal, and peripheral arteries. And importantly, we'll cover the patient perspectives gathered for these guidelines, which is quite unique. We'll wrap up by looking at the unresolved issues and where research needs to head next.
It's a comprehensive plan for a challenging topic, definitely demands our full attention. Hashtag CARC content, hashtag tech1, introduction, and general aspects of the guidelines.
Okay, let's start right at the beginning. The purpose of these European Society for Vascular Surgery guidelines. Why were they created? Why now? What's particularly noteworthy about them?
Well, they're quite significant because, as the source material explicitly states, this is actually the very first time that clinical practice guidelines specifically focused on vascular graft or endograft infection have been published by major scientific societies like the ESVS.
The first time.
Exactly. It really highlights the growing recognition of the specific challenge and the clear need for consolidated expert opinion on how best to manage it.
That is a crucial point. So what's their main aim then? What are they trying to achieve for clinicians, for you listening?
The central aim, really, is to provide practical help. Assistance for physicians involved in caring for patients where you suspect or have diagnosed a vascular graft or endograft infection. They're meant to guide the selection of the best management strategy, acknowledging that these cases, well, they present in so many different ways, different severities, different locations.
And who exactly are the intended users? Who did they write these guidelines for?
The target audience is quite broad, reflecting the fact that this is truly a multidisciplinary problem. It includes angiologists, vascular surgeons, cardiovascular surgeons, general surgeons too, infectious disease physicians, and radiologists. Basically, any specialist who might be involved in the diagnosis, the decision-making, or the actual hands-on care of these complex patients.
Got it. And they clearly define the target patient population too, patients with these infections in the supraaortic trunks, the thoracic or abdominal aorta, and the peripheral arteries. So pretty much the whole arterial tree where we commonly place prostheses.
Precisely. And, as with any clinical practice guideline, it's so important to remember their fundamental role. They are developed to promote a standard of care based on the best available evidence and, crucially, the consensus of experts within the ESVS. They're a tool, really, to help standardize approaches where possible and improve patient outcomes.
Yes, and you mentioned a really critical caveat earlier that's worth repeating. These are guidelines. They're not some rigid, legally binding standard that you have to apply identically to every single patient.
Exactly. Patient care is always individualized. It just has to be based on the unique characteristics of the patient right in front of you. This means considering the variability in their symptoms, their specific comorbidities, their age, and also the practical realities. What diagnostic techniques and surgical procedures are actually available at your local hospital? What's the local expertise within your team? Making that distinction between a guideline as a helpful framework versus a rigid one-size-fits-all standard is absolutely vital in day-to-day practice.
Okay, so we understand the why and who and the role. Let's shift to the how. The methods section is quite detailed on how these guidelines were actually built. Can you walk us through the writing committee? How did they ensure the right mix of expertise?
Sure. The members of the writing committee, they were carefully selected by the ESVS, working together with the European Association of Nuclear Medicine, that's EANM, and the Groupe de Recherche sur les Infections de Prothèses. The specific goal was to ensure they had comprehensive representation from all the key specialties. So the committee deliberately included not just vascular surgeons, but also radiologists and infectious disease specialists.
And transparency was a big deal here. How did they handle potential conflicts of interest?
Absolutely. Transparency was paramount. All the committee members had to provide detailed disclosure statements about any relationships that could possibly be seen as real or potential conflicts of interest related to the guideline topics. These were carefully reviewed and kept on file. And importantly, the source explicitly says that none of the committee members or the external reviewers involved received any financial support from third parties that was related directly or indirectly to developing or publishing these guidelines. Everyone signed declarations of interest to maintain integrity.
That's essential for trust in the recommendations. So how do they systematically gather the evidence? What was the approach to evidence collection?
It was a rigorous and systematic process. It started with a meeting back in Strasbourg in June 2017. There, the writing committee agreed on the guidelines' purpose, the topics, assigned tasks to subgroups, and set out the methodology for collecting evidence. And this initial search strategy was updated later to capture the newest literature. All the committee members were responsible for doing a systematic literature search for their assigned sections. They used specific databases, PubMed, Scopus, Accordia Source Clinical Trials Database, Cochrane Library. The first search covered 97 to November 2017, and then they updated it to February 2019, focusing on English language papers to keep it current.
Did they use any other methods besides just the database searches?
Yes. They supplemented the database search by carefully checking reference lists in the papers they found. And they also did manual searching, hand searching, for other relevant literature that might have been missed by the databases alone.
Were any types of publications specifically excluded?
Yes, the source mentions that abstracts were explicitly excluded from the formal review process.
And the general criteria for including studies in the evidence base?
The main focus was on peer-reviewed published literature, and specifically studies that presented predefined outcomes relevant to vascular graft or endograft infection. Now, single case reports or small case series, they weren't the primary evidence for recommendations, but they were included if they were considered really important for shedding light on a specific area or a rare situation where, frankly, higher level evidence just wasn't available. The selection process followed the well-known hierarchy, or pyramid, of evidence. Imagine a pyramid. Systematic reviews and meta-analyses at the top, then randomized controlled trials, then observational studies, and finally expert opinion at the bottom. So the level of evidence backing each recommendation really depends on the best evidence they could find on that specific subject.
Makes perfect sense for evidence-based guidelines. So how do they take all this gathered evidence and translate it into the actual conclusions and recommendations we see? How are those formulated and rated?
The process was based on both the availability and, critically, the quality of the scientific evidence reviewed by the rating committee. Conclusions were drawn from this analysis. Then, the recommendations for evaluating and treating patients were formulated based on these conclusions. And importantly, when high-level evidence was scarce or maybe conflicting, consensus among the experts on the committee, drawing on their collective experience, played a crucial role.
And they use a specific standardized grading system, right? Can you remind us how that works? The ESC system?
Yes, they adopted the well-established European Society of Cardiology, or ESC grading system. It uses a letter for the level of evidence and a class number for the strength of the class of recommendation. It gives clinicians a clear way to understand both the quality of the data and the expert's confidence level.
Let's break that down. First, the level of evidence. What do the letters A, B, and C mean in Table 1?
Okay, Level of evidence A. That means the recommendation is backed by data from multiple large randomized clinical trials or robust meta-analyses. That's the highest level. Level of evidence B means the data comes from a single large randomized trial or large, well-designed, non-randomized studies. Still strong evidence. Level of evidence C. This is the lowest level. It means the data is mainly based on expert consensus or maybe small studies, retrospective studies, or registries. This is often used when higher quality studies just aren't available, which is common in rare or complex conditions like these infections.
Okay, so A, B, C tells us about the study quality. And based on that, plus expert opinion, they assign a class of recommendation. What do the class numbers mean in Table 2? Remember, we pronounced them Class 1, Class 2, Class 3.
Right. Class 1. This is a strong recommendation. It means there's clear evidence or general agreement that a treatment or procedure is beneficial, useful, effective. It's typically phrased as is recommended. Class 2. This indicates conflicting evidence or differing opinions about usefulness. Because of this uncertainty, it's split further. Class 2A. This is a weaker recommendation than Class 1. It means the weight of evidence or opinion favors usefulness. It's often phrased as should be considered. It suggests the approach is reasonable, likely beneficial, but maybe not as definitively proven as Class 1. Class 2B. This is the weakest positive recommendation. Usefulness is less well established. It's phrased as may be considered, suggests it's an option, but the evidence is relatively weak or opinion is divided. And finally, Class 3. This is a recommendation against something. It means evidence or agreement shows it's not useful or effective, and maybe even harmful, clearly phrased as is not recommended.
That's very clear. So Class 1 is a strong do it, Class 2A is probably should consider it, 2B is maybe consider it, but evidence is weak, and Class 3 is don't do it. And the A, B, C level tells you the foundation. This system really helps interpret the recommendations.
Exactly. And the guidelines are thorough. They mention detailed evidence tables were built for each recommendation, listing the studies. These are available separately as supplementary material for anyone wanting to dig deeper.
Now, one of the most unique aspects, as you mentioned, is the inclusion of the patient's perspective. This isn't standard in clinical guidelines. Why was this included? What was the goal?
Including the patient's perspective, it reflects a broader, really important shift in healthcare towards shared decision-making and patient involvement in guideline development. The goals stated were democratization of decisions and, crucially, increasing the quality of those decisions. Engaging directly with patients who've lived through this provides insights that can improve both the validity and the practical relevance of the guidelines.
How did they gather this feedback? Was it just a survey?
No, it was more direct, more qualitative. They specifically interviewed European patients for this purpose. The group included representatives from patient associations focused on relevant areas like aortic dissection, infectious diseases, and also individual patients who had personally been treated for abdominal vascular graft infection by surgeons who were actually on the writing committee.
What were the main themes or questions that came out of those discussions?
The guidelines list 3 main questions that frame the feedback. 1. Did you feel your doctor gave enough information about the risk of infection when you had the initial procedure? 2. What did you think about the management once the diagnosis of infection was made? And 3. Did you feel your doctor gave enough information about the risks related to the infection itself? We'll definitely get into the specific, insightful answers later. They add a crucial human dimension.
Looking forward to that. Sounds vital. Before we leave the general aspects briefly, what was the document review process like? How was the draft checked?
It went through a thorough internal review by the writing committee first. Then it was sent for external revision by members of the ESVS Guidelines Committee and selected external experts not involved in the writing. Subsequent drafts were revised based on this feedback. The final document was formally approved by everyone, Writing Committee, Guidelines Committee, external reviewers, before submission in July 2019.
Sounds robust. And is there a plan for updates?
Yes, they explicitly acknowledge how fast things change in this field, technology, diagnostics, knowledge. So they state it's a specific aim of the ESVS to revise these guidelines periodically to keep them current.
Okay, that gives us a solid foundation. The purpose, the rigorous process, the grading system using ESE classes and levels, and the novel inclusion of patient perspectives.
A good starting point for the deep dive into the specifics.
Micro recap. So far, we've set the stage, exploring the European Society for Vascular Surgery guidelines on vascular graft and endograft infections. We learned these are the first dedicated guidelines from major societies built by a multidisciplinary team using systematic evidence collection and the European Society of Cardiology grading. That's Class 1, 2A, 2B, 3 for recommendation strength, and levels A, B, C for evidence quality. We also highlighted the inclusion of patient perspectives and the plan for future updates, #2, definition and diagnosis. Let's transition now into the absolutely critical area of definition and diagnosis. You can't manage something effectively if you can't reliably identify it. First, the definitions. Where did the guidelines start?
They begin by referencing the well-established criteria from the Centers for Disease Control and Prevention, the CDC, for surgical site infections, or SSIs, specifically the criteria for superficial and deep SSIs. While designed for general surgical wounds, these can be applied to help describe and categorize the incision site aspects of vascular graft infections.
Can you walk us through those CDC criteria from Table 3? Let's start with superficial surgical site infection.
Sure. The CDC criteria define a superficial SSI by needing three things. 1, the infection has to occur within 30 days of the surgery. 2, it involves only the skin and subcutaneous tissue of the incision. And 3, the patient needs at least one of the following: purulent drainage from the incision, organisms isolated from a culture of fluid or tissue from the incision, or sign symptoms like pain, tenderness, swelling, redness, heat, plus the incision is deliberately opened by a surgeon and is either culture positive or not cultured. But importantly, a culture negative result in that last scenario doesn't count.
And the diagnosis has to be made by a surgeon or attending physician. What about deep surgical site infection? How are those defined?
Deep SSI criteria are similar but go deeper and have a longer time frame if there's an implant. Again, 3 conditions. 1, infection within 30 days if no implant, or within 1 year if there is an implant, like a graft, and the infection seems related to the surgery. 2, it involves deep soft tissues, fascia, muscle layers. And 3, at least one of the following: purulent drainage from the deep incision, not from a deeper organ. A deep incision spontaneously opens or is opened by a surgeon. AD is culture positive or not cultured when the patient has fever over 38C or local pain tenderness. Again, culture negative doesn't count here. Or an abscess or other clear evidence of infection involving the deep incision found on exam, during reoperation, or on histology or radiology.
And again, diagnosed by a surgeon or attending physician. The guidelines also add helpful reporting notes, like not reporting simple stitch abscesses, but classifying any infection involving both superficial and deep sites as deep, reflecting the greater severity.
Yes, these CDC criteria provide a widely recognized framework, useful for the wound aspect. But as the source points out, they weren't designed specifically for graft involvement, which is really the core issue here.
Which is exactly where other classifications, more specific to vascular grafts, come in.
Exactly. The source mentions several older, established systems that focus more on graft involvement. There's the Zilagi classification. Grade 1 is just wound cellulitis. Grade 2 involves subcutaneous tissue. Grade 3 means the infection involves the vascular prosthesis itself.
Okay, Zilagi grade 3 is the key one for graft involvement. What about Samson?
The Samson classification is more granular, with 5 groups. Group 1, infection no deeper than dermis. Group 2, subcutaneous tissue but no contact with the graft. Group 3 involves the graft body but not the anastomosis. Group 4, exposed anastomosis but no bleeding or bacteremia. And Group 5, the worst, anastomosis involved with bleeding or bacteremia.
Gets more specific, especially around the critical anastomosis and the Bunt classification.
The Bunt classification is mentioned, particularly modified for peripheral grafts. The source specifically mentions a P0 graft infection, defined as infection of a cavitary graft. Examples given are aortic arch, thoracic abdominal interposition, aortoiliac, aortofemoral, and iliofemoral grafts.
The guidelines also mention differentiating early onset, less than 4 months post-op, versus late onset, more than 4 months for aortic infections.
Yes, this early versus late distinction is often applied to other locations too. However, the source explicitly states that the precise clinical relevance of strictly using this 4-month cutoff is still debated among specialists.
Micro recap. We've just covered the foundational definitions and classifications for vascular graft infections. We started with the CDC criteria for superficial and deep SSIs, providing a general framework. Then we moved to graft-specific systems like Zilagi, Samson, and Bunt P0, focusing more on graft involvement depth. We also noted the early versus late onset distinction, though its clinical relevance based solely on the 4-month mark is debated. Given the limitations of older classifications, the guidelines highlight a newer system, the MAGIC criteria. What's MAGIC, and why is it seen as a better approach?
MAGIC stands for the Management of Aortic Graft Infection Collaboration. This international group developed criteria aiming for a more standardized, comprehensive, and objective diagnosis of aortic graft infection, addressing shortcomings of previous systems. And while focused on the aorta, the principles are widely applicable.
How does MAGIC work? What's the underlying approach?
It uses a structured approach, combining evidence from 3 different domains: clinical or surgical findings, radiological findings, and laboratory findings. It lists major and minor criteria within each category. The diagnosis is made by combining evidence across these domains.
Okay, so combining different types of evidence. How do you use these criteria to go from just suspecting infection to making a definitive diagnosis?
According to MAGIC, infection is suspected if you have either 1 major criterion or any 2 minor criteria from the 3 categories combined. To make a definitive diagnosis, you need a higher threshold, at least 1 major criterion plus any other criterion, major and minor, from a different category. This requirement for evidence from more than 1 domain, like clinical plus imaging or clinical plus lab, increases diagnostic certainty.
That's a key distinction. Suspicion versus diagnosis, needing evidence from different categories. Can you give us some specific examples of major and minor criteria from each category in Table 5 that'll help visualize what these mean in practice?
Sure. Let's start with clinical or surgical findings. Major criteria here are things highly indicative of infection seen during surgery or inspection: pus confirmed by microscopy around the graft or in the aneurysm sac, an open wound exposing the graft, or a sinus tract communicating with it, or recovering organisms by culture from the explanted graft or an intra-op sample.
Those sound pretty definitive. What are the minor clinical surgical criteria?
Minor criteria are less specific: fever over 38°C, but only when graft infection is the most likely cause. Abnormally elevated inflammatory markers like CRP, WBC, ESR, again, only when graft infection is most likely. A new palpable mass or pseudoaneurysm expansion. Graft enteric erosion or fistula, or aortic stump sepsis after excision.
Okay, so interpreting non-specific signs like fever or high markers needs careful context. What about radiology? Major radiological criteria.
Major radiological signs are specific imaging findings based on timing. Paragraft fluid on CT seen more than 3 months after insertion, or paragraft gas on CT seen more than 7 weeks after insertion. Persistence beyond these times is highly suspicious.
Why those specific time frames, 3 months and 7 weeks?
Because some fluid, seroma, and trapped air are common right after surgery as part of normal healing. If they persist beyond these accepted time forms, it becomes abnormal and strongly suggests ongoing inflammation or infection.
Makes sense. And the minor radiological criteria.
Minor signs are less specific but support the possibility. New or enlarging fluid gas on CT within those timeframes where persistence becomes major, pseudoaneurysm formation, focal bowel wall thickening near the graft, suggesting fistula, descitus or osteomyelitis nearby, suspicious metabolic activity on FDG-PET-CT, or radiolabeled leukocyte uptake on WBCS.
So advanced imaging like PET-CT and WBCS contribute minor criteria if they show suspicious uptake. Finally, the laboratory category. Major lab criteria.
Major lab criteria provide direct evidence: organisms recovered from an aseptically obtained sample of paragraft fluid, tissue, or pus, a positive culture from drainage from an incision or sinus tract linked to the graft, histopathology showing paragraft inflammation consistent with infection, or a positive gram stain from an intra-op sample.
And minor laboratory criteria.
Minor lab criteria are less definitive, actually the same as 2 minor clinical ones: positive blood culture, with no other obvious source, fever over 38°C with graft infection most likely, or abnormally elevated inflammatory markers, CRP, ESR, WBC with graft infection most likely. And as the source emphasizes, careful interpretation is key. Fever alone isn't specific. Pus needs microscopic confirmation. Direct communication, like an aortoenteric fistula, is a major criterion. Non-specific symptoms like fatigue are not major criteria on their own.
That detailed breakdown of MAGIC with examples and nuances is incredibly helpful. It clarifies what raises suspicion and what combination from different categories confirms the diagnosis. Let's try a quick board-style scenario. Okay, imagine a patient, 8 months post-open aortic bifemoral bypass. They present with a draining sinus in the left groin incision. A CT shows new paragraft fluid around the left limb, not seen 4 months ago. Blood cultures are negative. CRP and WBC only mildly up. According to MAGIC, is this a diagnosis of graft infection?
Let's apply it. Draining sinus-exposed graft, that's a major clinical surgical criterion. New paragraph fluid on CT at 8 months, that's a minor radiological criterion. Negative bloods, mildly raised markers, those are minor lab criteria. For diagnosis, you need at least one major criterion plus any other criterion from a different category. Here we have a major clinical sinus ND, a minor radiological new fluid. So yes, this patient would meet the magic criteria for a definitive diagnosis of vascular graft infection.
Great example, really highlights needing findings from different categories. Thanks.
Yeah.
Let's move to epidemiology, specifically incidence. How common are these infections generally? Does it vary?
They're relatively uncommon overall, but very serious when they happen, usually multifactorial. The incidence varies widely, depending on location, graft type, open versus endo, procedure type, patient factors, and length of follow-up. Longer follow-up catches more late infections.
Is there any suggestion about a difference between endografts and traditional grafts?
Yes, the source mentions a hypothesis or suggestion that endograft infection might actually be more frequent. The idea is there's often less tissue ingrowth into the endograft fabric. It's often surrounded by thrombus or aneurysm sac, which might be less resistant to bacterial colonization than a well-incorporated open graft in healthy tissue.
Interesting hypothesis. Shifting back to the patient, the guidelines stress the clinical presentation is highly variable.
That's right. As we saw with MAGIC, it can range from subtle, maybe just some skin redness or non-purulent wound drainage, all the way to severe sepsis or catastrophic anastomotic rupture and shock.
What are the more common or classic signs that might raise suspicion initially?
Often, unexplained fever is key, especially if there's no other clear source. Similarly, unexplained leukocytosis, high WBC, with a raised C-reactive protein, maybe with fever, can sometimes be the only sign, particularly in deep-seated infections. Other things you might see include a localized abscess or mass, septic emboli causing problems elsewhere, septic shock, bleeding, like melena, heminemesis, hematuria if there's a fistula, or nonspecific abdominal symptoms like ileus with aortic infections.
Given this variability, what's the recommendation when you just suspect infection based on some of these signs?
The guideline is clear here. When vascular graft or endograft infection is suspected, a complete clinical and biochemical evaluation according to the MAGIC criteria is recommended. That's recommendation 1, class 1, level C.
Okay, let's decode that. Class 1 is recommended because experts agree it's beneficial. Level C, based mainly on expert opinion, small studies or registries, not high-level trials. So even without level A or B evidence, the strong expert consensus is to use the structured MAGIC criteria for evaluation whenever you suspect infection.
Precisely. It's considered the best available way to standardize the initial assessment and guide further steps, despite the lower level of evidence for that specific recommendation.
Micro recap. We've just covered definitions and diagnosis. We looked at CDC, SSI criteria, and graft-specific ones like Silligy, Sampson, Bunpioa. We detailed the MAGIC criteria using major-minor findings across clinical, radiological, and lab categories for suspicion versus diagnosis and applied it in a scenario. We touched on variable incidence, maybe higher with endografts, and the wide range of clinical presentations, stressing that a full MAGIC evaluation is recommended, class 1 level C, when infection is suspected. Moving from clinical suspicion, let's get into microbiology. Identifying the bug and its sensitivities is vital for treatment. How often do we actually manage to isolate the responsible microbe?
Pretty often, actually. If you use the right sampling techniques, microorganisms can be isolated in a high percentage of cases. The source mentions culture positivity rates between 75% and sometimes as high as 98%. So getting microbiological proof is usually achievable.
That's high, definitely worth pursuing. What are the typical pathogens? Any specific bacteria commonly found?
Gram-positive bacteria are the most common, found in up to 58% of cases. This includes things like Enterococci, Staphylococcus aureus, and coagulase-negative Staphylococci like Staphylococcus epidermidis. Gram-negatives account for about 34%, and anaerobes around 8%. Organism virulence also matters for outcomes, especially reinfection risk. A meta-analysis mentioned classified organisms like Staph aureus, Enterobacteriaceae, Pseudomonas aeruginosa, beta-hemolytic strep as more virulent. In contrast, skin flora like Staph epidermidis, Corynebacterium, Cutibacterium acnes were less virulent. That analysis found virulent organisms were significantly linked to a higher risk of reinfection.
So knowing the specific bug and its virulence matters. What about antibiotic resistance? Does that impact healing?
Intuitively, resistance should reduce the chance of healing. However, the source notes that a clear, definitive link between specific resistance patterns and healing rates hasn't been clearly established specifically for vascular graft infections in the existing literature.
And biofilms, They're notoriously difficult in prosthetic infections, right?
Yeah.
How do they affect antibiotics?
Yes, biofilms are absolutely critical here. Bacteria embedded in that protective biofilm matrix on the graft surface are much less susceptible to antibiotics than free-floating bacteria. The biofilm hinders antibiotic penetration. The source mentions that susceptibility to antibiotics that work well in biofilms, like rifampicin combinations for staph infections, is important and can impact reinfection risk. You might need higher concentrations or specific combinations to beat the biofilm.
Given how important it is to identify the bug and its sensitivities, especially with virulence and biofilms in mind, what's the recommendation on getting microbiological proof?
A strong recommendation. When infection is suspected, every effort should be made to obtain microbiological proof by isolating and identifying the causative microorganism. That's recommendation 2, class 1, level C.
Okay, class 1, again, is recommended based on expert consensus and practice. Level C, based on expert opinion, small studies. So even without level AB evidence proving the impact, experts strongly feel identifying the bug is mandatory.
Exactly. Essential for guiding therapy. So how should clinicians get this proof? What are the best sampling techniques?
Ideally, collect samples before starting antibiotics, if possible. Accuracy depends on avoiding contamination and getting enough material. Send samples quickly to the lab. Store at 4 degrees Celsius if delayed.
What types of specimens are most meaningful?
Directly obtained specimens from the site are best. This includes the explanted prosthetic material itself, intraoperatively obtained tissue or graft biopsies from the infected area under aseptic conditions, or getting at least 3 separate samples from a paragraph fluid collection. The source mentions using pediatric anaerobic tubes for small fluid volumes.
Image-guided aspiration, ultrasound or CT, can also provide accurate diagnostic material without open surgery. And studies show if a graft looks well incorporated, negative cultures are reliable, 97% for ruling out infection there. If it looks disincorporated, that predicts a positive culture, 89% if infection is present.
And there's a clear preference for tissue or graft samples over swabs.
Yes, absolutely crucial. Tissue specimens or a piece of the graft are explicitly superior to swabs, even sterile intra-op swabs. The guideline recommendation supports this. To get microbiological proof, the yield of at least 3 deep rather than superficial samples should be considered. That's recommendation 3, class 2A, level C.
Let's decode that. Class 2A, weight of evidence opinion favors it, so should be considered. Level C, based on expert opinion small studies. So a strong suggestion based on expert consensus for better results. Why are swabs less ideal, even intra-op?
Swabs make it hard to tell colonizers from true pathogens, potentially leading to overtreating with broad-spectrum antibiotics. Plus, bacteria don't transfer well from swabs to media, and inoculum isn't evenly spread. If you must use swabs, the source recommends polyethylene terephthalate ones based on studies showing better collection release.
Interesting detail. The source also mentions an innovative collection technology, micro-TT-TECT.
Yes, mentioned as a potential future tool, it's designed for contamination-free sampling and might help dislodge biofilm bacteria, potentially improving detection rates.
What about indirectly obtained specimens, like blood cultures or superficial wound samples? Are they reliable?
They can sometimes provide supplementary info, especially if direct samples aren't possible. Surgery, no reoperation. Blood cultures are positive in about 35% of cases pre-op and match the operative culture in 20 to 30%. However, the guidelines are cautious about other indirect samples, swabs, biopsies, aspirates from superficial wounds, draining sinuses, or nearby structures. These always contain skin flora or contaminants and might not reflect the true deep pathogen. The source warns to consider results from indirect specimens cautiously due to lower specificity.
There's also a specific recommendation about culturing negative pressure wound therapy foams.
Yes, and it's a negative one. Microbiological investigation of negative pressure wound therapy and PWT foams should not be performed to support diagnosis. That's recommendation 4, class 3, level C.
Class 3. Not recommended as it's not useful effective based on expert opinion small studies. Level C. A clear warning against relying on form cultures.
Exactly. Finally, on lab processing, different techniques can enhance recovery, especially of biofilm formers. Things like direct streaking, broth culture, homogenization, sonication of graft material, vortexing tissue samples.
And a recommendation specifically on sonication?
Yes. Sonication of intraoperatively harvested graft material may be considered to improve detection rate. That's recommendation 5, class 2B, level C.
Class 2B, usefulness less established, so may be considered. Level C, based on expert opinion small studies. So it's a technique some use might help yield, but evidence isn't robust yet. Micro recap. We've detailed the microbiology of these infections. High culture positivity is achievable. We discuss common pathogens, virulence impact, sampling techniques, deep tissue grafts superior to swabs, caution with indirect samples, and the recommendation against culturing NPWT foams. Advanced lab techniques like sonication, Class 2B Level C, might help. Getting samples is often guided by suspecting the diagnosis via imaging. Imaging techniques are crucial, but what's the main challenge?
The primary challenge is reliably differentiating true infection from normal post-op changes, like inflammation, hematoma, or seroma, especially early on when some changes are expected.
Let's go through the modalities, starting with ultrasound, US. What's its role?
Ultrasound is low cost, readily available, good initial screen, especially for superficial peripheral grafts, groin, arm.
What ultrasound findings might suggest infection?
Things like a pseudoaneurysm, gas bubbles persisting beyond 7 weeks post-op, or purely anechoic fluid collections persisting beyond 3 months. It can help differentiate hematoma from abscess, check for graft thrombosis, and guide needle aspiration for samples.
But it has significant limitations.
Yes, especially for deeper grafts. High interoperator variability. Limited value in central grafts due to bowel gas or obesity. And crucially, a normal ultrasound doesn't rule out infection if there's no large fluid collection. Overall sensitivity is relatively low compared to cross-sectional imaging.
Given those limits, what's the recommendation on using ultrasound alone?
Clear recommendation. Use of ultrasound as the sole diagnostic modality is not recommended. That's recommendation 6, class 3, level C.
Class 3. Not recommended on its own. Level C, based on expert opinion small studies. A clear warning against relying solely on ultrasound for deep infections. What about computed tomography angiography, CTA?
CTA has long been the initial reference standard because it's excellent at visualizing anatomy. With IV contrast, it shows signs like ectopic gas, paragraph fluid, soft tissue enhancement, pseudoaneurysm, focal bowel thickening, wall discontinuity. For aortoenteric fistula, it might even show contrast leaking into the bowel.
So it shows the anatomy well. But how good is it at actually diagnosing infection, its sensitivity and specificity?
Its performance for diagnosing infection is moderate and variable. A meta-analysis mentioned found pooled sensitivity was 0.67, specificity 0.63. Figure 1 shows this performance compared to others. The conclusion was that isolated CTA often isn't enough to definitively establish the diagnosis. A negative or equivocal CTA doesn't rule out infection.
Key point, first step, but often not the last word. What's the recommendation for using CTA?
Despite limitations in definitive diagnosis alone, CTA is recommended as the first-line diagnostic modality. That's recommendation 7, class 1, level B.
Class 1 is recommended as the initial test. Level B, based on single, large RCT or large non-randomized studies, reasonable evidence. So it's a mandated first step, even if often insufficient alone.
Right. As the source and figure 2 workflow show, standalone CTA can confirm diagnosis if findings are really convincing, e.g. clear fistula, lots of late gas. But if CTA is non-convincing or equivocal, a second, more functional imaging modality like FDG-PET-CT or WBCS-SPECT-CT is often needed to confirm infection and map its extent.
What about magnetic resonance angiography, MRA? Where does that fit?
MRA hasn't been studied as much as CTA for this specific use. Some suggest it might offer better anatomical functional info and tissue characterization. Combining FDG-PE with MRA is also mentioned for providing molecular info with localization.
Are there specific MRA findings suggesting infection?
Yes. Collections that are hypointense on T1 images and hyperintense on T2 images persisting more than 6 weeks post-op strongly suggest infection. Performance-wise, one series reported sensitivity of 0.68 and high specificity of 0.97 for suspected aortic infections.
So quite specific if positive, but maybe less sensitive. Main limitations.
Lower availability than CT, long scan times leading to motion artifacts. It's not currently a first-line modality unless CTA is contraindicated.
And the recommendation for MRA?
If CTA is contraindicated, AG allergy, renal failure, MRA may be considered. That's recommendation 8, class 2B, level C.
Class 2B, usefulness less established, so may be considered. Level C, based on expert opinion small studies. An option if CTA can't be done, but not the preferred initial test. Micro recap. We've looked at anatomical imaging. Ultrasound is limited alone for deep infections. CTA is the recommended first line, class 1 level B, but its moderate performance often requires further imaging. MRA is a class 2B level C alternative if CTA is contraindicated. Beyond anatomy, the guidelines discuss nuclear imaging techniques, combining anatomical scans with functional information about inflammation or white cell activity.
Yes, these are valuable because they show metabolic activity, which is often much higher infection compared to sterile inflammation. Key examples are 18F-fluorodeoxyglucose positron emission tomography combined with computed tomography, FDG-PET-CT, and white blood cell scintigraphy combined with single photon emission computed tomography combined with computed tomography, WBCS-SPECT-CT. They can potentially be more specific for infection. They might differentiate graft infection from just surrounding soft tissue inflammation based on uptake patterns, intensity, or changes over time with WBCS.
Let's look first at positron emission tomography with FDG. How does this work for infection?
FDG-PT works because cells with high glucose metabolism take up the radioactive glucose tracer. This includes inflammatory cells like leukocytes migrating to the infection site, and also bacteria and fungi themselves. This increased activity shows up on the scan. It can help differentiate a simple fluid collection from actual graft involvement by showing activity on the graft, but must be combined with low-dose CT for anatomical localization, hence FDG-PET-CT. It's now established for suspected graft infection, providing accurate localization. There are procedural guidelines from ENM and SNMMI, and harmonization efforts like EARL aim to standardize protocols.
How are FDG-PET-CT scans interpreted for graft infections? What criteria are used?
Different methods. Quantitative, like maximum standardized uptake value, SUV max, tissue to background ratio, or visual assessment of uptake pattern, focal, diffuse, homogeneous, and intensity. An SUV max 8 in the paragraft area was suggested as a potential cutoff in small studies, but might not be universal. A linear, diffuse, homogeneous uptake pattern projecting right onto the graft is highly suggestive of infection. Interestingly, factors like diabetes or ongoing antibiotic use, previously thought to affect accuracy, were shown in recent studies not to significantly impact FDG-PET-CT diagnostic accuracy in this setting.
That's valuable for clinicians. What about its overall diagnostic performance?
The meta-analysis showed FDG-PT alone had high sensitivity, 0.94, but lower specificity, 0.70. Combining it with CT, FDG-PET-CT, improved results. Sensitivity 0.95, specificity 0.80. Figure 1 shows it's generally more sensitive than CTA and WBCS.
So quite sensitive, reasonably specific, better than standalone CTA, especially if CTA is unclear. What's the recommendation for using FDG-PET-CT?
For patients with clinical suspicion and non-convincing CTA findings, FDG-PET combined with low-dose CT is recommended as an additional imaging modality. That's recommendation 9, class 1, level B.
Class 1 is recommended. Level B, based on single large RCT or large non-randomized studies. So when initial CTA is inconclusive, FDG-PET-CT is the recommended next step, especially valuable for central grafts.
Correct. Now, the other major nuclear technique, white blood cell scintigraphy, WBCS, how does this detect infection?
WBCS works by labeling the patient's own white blood cells with a radioactive tracer and then visualizing where they accumulate. They migrate to areas of active infection or inflammation. Procedural guidelines exist for labeling and imaging.
Diagnosis relies on showing pathological accumulation at the suspected site. Unlike PT-CT, it usually needs at least 2 scans, 2 4 hours post-injection and 20 24 hours post-injection. An increase in intensity or size over time is considered positive. If positive, SPECT-CT is mandatory for exact anatomical localization. Is it soft tissue, the graft itself, or extending elsewhere?
Strengths and limitations compared to PT-CT or CTA.
Major strength, generally considered very specific for acute bacterial infection. Limitations. More time-consuming and labor-intensive due to the lab labeling step, not available everywhere, requires multiple time points. Accuracy can be lower centrally, aorta, due to normal tracer elimination via bowel and physiological uptake in bone marrow, making interpretation tricky sometimes. Antigranulocyte antibody scintigraphy is mentioned as an alternative avoiding lab labeling, but also needs dual time points and has similar issues with physiological uptake. Generally lower accuracy than WBCS.
And the performance data for WBCS.
The meta-analysis estimated sensitivity of WBCS without SPECT-CT at 0.83, specificity 0.89. Figure 1 shows it having potentially higher specificity but slightly lower sensitivity than FDG-PET-CT.
So maybe more specific, which is valuable, but potentially less sensitive, and more logistical hurdles. What's the recommendation for using WBCS?
It's specific to location. In patients with clinical suspicion of peripheral vascular graft or endograft infection, WBCS combined with SPECT-CT, if available, is recommended as additional imaging when initial CTA is non-convincing. That's recommendation 10, class 1, level B.
Class 1 is recommended. Level B based on single RCT or large non-randomized studies. Interesting, it specifically targets peripheral infections, perhaps leveraging its higher specificity where normal central uptake isn't an issue. complementing FDG-PET-CT's broader recommendation.
Yes, that recommendation highlights where WBCS-SPECT-CT is considered most useful according to the guidelines.
Micro recap. We've explored nuclear imaging. FDG-PET uses glucose metabolism, offers high sensitivity, reasonable specificity, 0.950, 0.80, and is recommended, Class 1 Level B, when initial CTA is non-convincing. WBCS-SPECT-CT visualizes white cell accumulation, is highly specific, 0.89, particularly recommended, Class 1 Level B, for peripheral infections when initial CTA is equivocal, but is more time-consuming and can be challenging centrally. Bringing these modalities together, the guidelines propose a clear imaging workflow in Figure 2. Can you describe that proposed algorithm? How does a clinician navigate it?
The workflow in Figure 2 guides the optimal sequence based on suspicion and location. It splits into thoracic abdominal grafts versus limb grafts, peripheral. For both, the initial step is CTA or MRA if CTA is contraindicated.
Okay, CTA first for both central and peripheral. What happens next?
It branches based on the CTA findings. If the CTA is convincing for infection, unequivocal signs like late gas, clear fistula, then the workflow suggests no other imaging is strictly required for diagnosis. Diagnosis confirmed by CTA alone in clear cases.
But CTA is often non-convincing. What's the recommended next step then?
If the initial CTA is non-convincing, suspicion remains, but CTA is negative or equivocal, the workflow says proceed to either FDG-PET-CT or WBCS-SPECT-CT. The choice might depend on availability, expertise, location, though the figure shows them as alternatives. As we saw, Rec 9 supports FDG-PET-CT generally. Rec 10 supports WBCS-SPECT-CT specifically for peripheral. The algorithm adds a note. Even if CT is convincing in high-grade infections, second modality, PET-CT and/or WBCS-SPECT-CT, may still be useful to fully map the extent for surgical planning.
And a practical note on availability?
Yes, the figure notes WBCS can be applied if available. If not, FDG-PET-CT can be used as the alternative second-line test when CTA is non-convincing. Acknowledging practical access influences the choice.
Mega recap. We finished our deep dive into definition and diagnosis. We covered CDC, SSI criteria, and graft-specific ones. Syllogy, Samson, Bunt P0. We detailed the MAGIC criteria combining clinical, radiological lab findings for suspicion versus diagnosis. We discussed microbiology, pathogens, virulence, biofilms, sampling superiority of deep tissue graft. Then we reviewed imaging, ultrasound limited, CTA, first-line moderate performance, MRA, alternative, and nuclear options, FDG-PET-CT, sensitive, recommended for non-convincing CTA, and WBCS-SPECT-CT, specific, recommended for peripheral non-convincing CTA. We concluded by describing the imaging workflow algorithm guiding modality choice based on initial CTA findings. Micro recap. Quick reminder on imaging workflow performance. CTA is the first step, but often needs follow-up with nuclear imaging, FDG-PET-CT or WBCS-SPECT-CT, if not convincing. CTA has moderate sensitivity specificity, 0.670, 0.63. FDG-PET-CT is generally more sensitive, support 9.5. WBCS-SPECT-CT more specific, 0.89, and making them valuable second-line tests. #tag3. Strategies to prevent graft or endograft infection. Now we've thoroughly explored diagnosis. Let's shift focus entirely to prevention. What concrete steps can reduce the risk of these challenging infections happening in the first place? Let's start with the materials themselves. Do the raw materials influence risk?
The source discusses common materials. Polymers like polyethylene terephthalate, PET, or expanded polytetrafluoroethylene, EPTFE, for soft grafts, and metal alloys like nitinol for stents. The main reason for choosing these is chemical and mechanical stability, durability, not inherent antimicrobial properties. These raw materials can be used plain or associated with adjuncts like impregnation or surface treatments for specific properties, maybe antimicrobial effects, which we'll discuss later for treatment grafts. However, the source clearly states there's no strong evidence of significant differences in inherent infection susceptibility of the synthetic raw biomaterials themselves when used as standard grafts.
So no clear winner between basic PET and basic EPTFE just based on the material regarding infection.
Correct. No clear consensus. In vitro and in vivo studies comparing PET and EPTFE give conflicting results. Some find no difference. Others suggest maybe less bacterial adherence for EPTFE. Similarly, studies comparing PET and bovine pericardium patches found no significant difference in resisting infection experimentally. While the base material might not dominate, other factors matter. Graft configuration, knitted versus woven, early protein adhesion, tissue healing sequence can influence bacterial adherence. Some bacteria, like coagulase-negative staph and strep viridans, have a high propensity for foreign materials. One study found greater affinity of some strains to velour knitted PT than standard EPTFE.
What about alloys for stents grafts? Any difference there?
Source says no demonstrated difference in infection susceptibility between different alloys currently used.
Okay, so while surface modifications might offer resistance, topic for later, the core material lie itself doesn't seem proven different. Let's move to logistics and perioperative care. This is where practical prevention happens. What about screening for Staphylococcus nasal carriage? Relevant.
Nasal carriage of Staph aureus is common, and Staph aureus is a frequent, often virulent cause of these infections. So logically, screening and decolonizing before surgery seems like it could help. The source discusses studies. One prospective PCR study found no difference in carriage rates between patients who got SSIs and those who didn't in general vascular surgery. However, another study focused specifically on aortoiliac surgery patients. They screened for Staph aureus carriage. If positive, patients got mupirocin nasal ointment and chlorhexidine baths pre-op. This was linked to a significant drop in Staph aureus-related SSIs, 1.3%, 13.6% in untreated carriers.
So targeting Staph aureus carriage reduced Staph aureus SSIs, but not overall SSIs from any bacteria.
Correct. It didn't significantly decrease SSIs from other bacteria, possibly due to competing bacteria remove one, another takes over. But reducing Staph aureus SSIs is still meaningful, suggesting this strategy can be beneficial, especially for high-risk procedures where Staph aureus is a major concern.
Provide some evidence for considering decolonization selectively. What other evidence-based aspects of general perioperative care are important for preventing SSIs, which we know is a strong risk factor for graft infection?
Evidence-based measures to cut general SSI risk are crucial. Regarding pre-op prep like showering hair removal, a meta-analysis showed no clear benefit from antiseptic bathing over plain bathing. But proper skin prep in the OR is vital. Other peri-op measures have been shown to significantly cut SSI risk. One large study found a bundle of measures reduced SSI risk by 51% in elective open-endo amputation surgery. Key measures included maintaining perioperative normothermia, normal body temp, removing hair the day before surgery using clippers, not razors, to avoid skin trauma, and strip aseptic technique in the OR.
Fundamental surgical care principles, extra critical with implants. What about antimicrobial prophylaxis? Seems like a cornerstone.
Absolutely. Prophylaxis antibiotics around surgery time is key. A meta-analysis showed prophylactic systemic antibiotics in arterial reconstructions significantly cut the risk of both wound infection, relative risk 0.25, a 75% cut, and early graft infection, RR 0.31, a 69% cut. That's substantial. Based on this strong evidence, perioperative systemic antimicrobial prophylaxis is recommended for all patients having open or endo AAA repair. Regarding duration, giving prophylaxis for more than 24 hours post-op doesn't seem to add benefit compared to shorter courses. Single dose or just a few hours post-op.
So usually just a dose or two around surgery is enough based on duration evidence. What about choice of antibiotic?
Initial choice is empirical, covering likely SSI bacteria. Must achieve good tissue levels at incision time and throughout the procedure. First or second-gen cephalosporins are common choices. Good tolerance. Spectrum covers methicillin-susceptible staph, strep, some gram-negatives. The meta-analysis of 22 RCTs on prophylaxis found it cut SSI risk, RR 0.25, and early VGI, RR 0.31. It found no difference in protective effect between first-second-gen cephalosporins, penicillins with inhibitors, aminoglycosides, or vancomycin.
What about covering MRSA or coagulase negative staph? Should prophylaxis routinely include this?
Coverage for MRSA and or coagnex staph may be considered. Decisions should be based on local prevalence and patient risk factors. However, studies comparing regimens with MRSA cover, cefazolin plus Ventapto, versus without cefazolin alone, haven't consistently shown a significant difference in overall SSI rates.
So you might consider adding MRSA cover based on local factors, but evidence cited doesn't show clear overall benefit versus standard cover. What's the formal guideline recommendation for periop prophylaxis?
A strong, high-level recommendation. Administration of antimicrobial prophylaxis with broad-spectrum antibiotics covering gram-positive and gram-negative bacteria given intravenously within 1 hour before incision is recommended. That's recommendation 11, class 1, level A.
Let's break that down. Class 1 is recommended as definitively beneficial. Level A based on multiple large RCTs meta-analyses, highest level evidence confirming importance of appropriately timed broad-spectrum periop antibiotics.
Exactly, one of the most robust recommendations in the guideline for prevention.
One final point on periop care. Wound closure. Does the technique matter for preventing SSIs?
Yes, apparently even meticulous closure details matter. A large registry study cited 2012-2016 found meticulous wound closure using a monofilament absorbable suture was statistically superior to using staples in decreasing SSI rates. So careful technique and material choice at the end matters.
Micro recap. We've covered key prevention strategies. Raw materials don't show strong inherent differences. Perioperative care is crucial. Consider Staph aureus nasal decolonization, sub-evidence, general SSI prevention bundles, normothermia, clipping hair day before, aseptic technique. Strong Class 1 Level A recommendation for periop, broad-spectrum IV antibiotics within 1 hour before incision, duration 24-at not needed. Meticulous wound closure with monofilament suture superior to staples. Beyond the immediate periop period, there's the risk of secondary hematogenous seeding bacteria from elsewhere landing on the graft. The source discusses this, using the prosthetic heart valve analogy regarding antibiotic prophylaxis during dental extraction.
Yes, the idea is, like prosthetic valves, vascular grafts are foreign bodies potentially at risk any time post-implantation from bacteria entering the bloodstream from a distant source. This is secondary hematogenous infection. Dental procedures are a known source of transient bacteremia. The guidelines mention that prophylaxis recommendations after graft implantation specifically for this risk might follow those from cardiology societies, ESC, ACHA, for prosthetic valves.
And what do those valve guidelines say about dental prophylaxis?
Recent guidelines cited recommend prophylaxis for prosthetic valve patients undergoing high-risk dental procedures, those manipulating gums or tooth roots, perforating oral mucosa, including scaling and root canals.
So, applying this principle prophylaxis before high-risk dental procedures to vascular graft patients has been proposed.
Yes, based on the analogy, proposed especially for patients with aortic prostheses, open or endo, undergoing these high-risk procedures.
Are there specific ESVS recommendations on this?
Yes, two related ones. First, preparing the patient before implantation. Before implanting any graft endograft, elimination of potential sepsis sources, especially dental, should be considered. That's recommendation 12, Class 2A, Level C.
Class 2A. Weight of evidence opinion favors it. Should be considered. Level C. Expert opinion small studies. Reasonable practice based on principle.
And second, prophylaxis after implantation. Antimicrobial prophylaxis to prevent VGEI should be considered before any dental procedure involving manipulation of gingival periapical region or perforation of oral mucosa, including scaling root canals. That's recommendation 13, also Class 2A, Level C.
Again, Class 2A Level C should be considered based on expert opinion and analogy, not high-level direct evidence for vascular grafts. Highlights expert consensus supports this practice to minimize theoretical risk. Mega recap. We've explored prevention strategies. Raw materials show no strong inherent differences. Periop care is key. Consider staph nasal decolonization, general SSI prevention, normothermia clipping, asepsis. Strong Class 1 Level A recommendation for periop broad-spectrum IV antibiotics within 1 hour pre-incision. 24 duration not needed. Meticulous suture closure better than staples. For late hematogenous risk, consider eliminating dental sepsis pre-implant, Class 2A Level C, and consider antibiotic prophylaxis for high-risk dental procedures post-implant. Class 2A Level C, analogous to valve guidelines. Micro recap. Quick reminder on antibiotic prophylaxis. Class 1 Level A for periop broad-spectrum IV antibiotics within 1 hour pre-incision. Class 2A Level C to consider prophylaxis for high-risk dental procedures post-implant based on expert opinion and analogy. Hashtag treatment general aspects. Now we get to the core issue, treatment of established infections. What are the fundamental general principles for managing these complex and dangerous infections?
The source emphasizes right away that given the complexity and high stakes, effective management absolutely requires a specialized approach involving a multidisciplinary team. No single specialty usually has all the necessary expertise.
What's the recommendation regarding where these patients should be treated? Can they be managed anywhere?
A clear recommendation here. For diagnosis and treatment of VGBI, it is recommended that the patient be transferred to a specialized high-volume center with demonstrated multidisciplinary experience. That's recommendation 15, Class 1, Level C.
Let's decode that. Class 1 is recommended based on expert opinion agreement. It's beneficial. Level C based mainly on expert opinion from experience, not comparative trials. So experts strongly feel these complex cases belong in specialized centers with experience.
Exactly. The source lists the key specialties for this team: vascular surgeons, radiologists, imaging intervention, microbiologists, bug sensitivities, infectious disease specialists, antibiotics, anesthetists, complex surgery, plus GI or pulmonary specialists if there's a fistula. The reason is clear. Diagnosis needs advanced imaging, surgery is intricate and high risk, and antimicrobial therapy is complex. resistance, biofilms, duration. Requires specialized expertise only found consistently in high-volume centers.
Speaking of antimicrobial therapy, what's its fundamental role once infection is established?
It's not optional, it's fundamental and mandatory. Antimicrobial therapy is recommended in every patient with an infected graft or endograft. That's recommendation 14, class 1, level B.
Class 1 is recommended as beneficial effective. Level B, based on single large RCT or large non-randomized studies, reasonable evidence. So good evidence supports antibiotics for every confirmed VGEI patient.
Yes, essential, alongside potential surgery. Regarding duration, lifelong antimicrobial therapy is often necessary, especially if the infected prosthetic material isn't or can't be completely removed, acknowledges the difficulty of eradicating bugs from foreign bodies.
Lifelong antibiotics a big burden. How is the initial antibiotic choice made?
Initially, it's empirical. Before you know the specific bug and sensitivities, you choose based on likely pathogens, Staph aureus, gram-negatives, and local resistance patterns. Aim for broad spectrum initially, e.g. anti-staph beta-lactam plus inhibitor or carbapenem. Once cultures are back, switch promptly to targeted therapy based on sensitivities. Considering local resistance patterns and patient risk factors, recent hospitalization, prior antibiotics, is key for empirical choice.
Given the complexity of evolving therapies, resistance, biofilms, what's the role of infectious disease specialists?
The guidelines are very strong here. Antimicrobial therapy management must be done by an infectious diseases specialist within the multidisciplinary team. They ensure optimal empirical choice, de-escalation, manage interactions, determine duration and route, IV versus oral, especially crucial for potential lifelong therapy. The source also emphasizes antibiotics are often adjunctive to surgery. Alone, they're rarely sufficient, especially with a foreign body, mainly due to biofilms. Bacteria and biofilms are less susceptible, may need higher concentrations or combinations, like rifampicin combos for staph, to penetrate and work. Optimal duration, if complete excision is achieved, is controversial, not detailed in this general section.
Micro recap. We've covered general treatment principles. Key points.
Yeah.
Strong recommendation, Class 1 Level C, for management in specialized high-volume centers with a multidisciplinary team. Antimicrobial therapy is mandatory, Class 1 Level B, in every patient, often lifelong if graft remains, and must be managed by infectious disease specialists due to complexities. Another general aspect, infection control within the hospital. Isolation for certain patients. Who needs it?
Specific isolation for patients colonized or infected with multi-drug-resistant MDR bacteria. That includes MRSA, methicillin-resistant coag-neg staph, ESBL-producing Enterobacteriaceae, or glycopeptide-resistant Enterococci. These patients should be isolated and remain isolated during their hospital stay. Why? To prevent spreading these tough bugs to others. Carriage is often prolonged, especially in patients on antibiotics. Standard precautions, gloves for biologicals, apply to all. Enhanced precautions for MDR include a gown for contact, mask if pulmonary involvement. Applies to both colonized and infected patients.
Mega recap. We've covered general treatment aspects. Need for multidisciplinary team in specialized center, Class 1 Level C. Antimicrobial therapy mandatory, Class 1 Level B. Often lifelong if graft remains, must involve ID specialists. Specific isolation for MDR patients. Micro recap. Key general principles. Manage in specialized center with MDT. Antibiotics mandatory, often lifelong, managed by ID. Isolate MDR patients, #5. Supra-aortic trunks. All right, let's apply these principles location by location, starting with the supra-aortic trunks, SAT, carotids, subclavians, brachycephalic.
Yes, infections here, like after carotid surgery or arch repair, are relatively rare, maybe 0.53% incidence. But when they happen, outcomes are grim, high rates of stroke, mortality up to 25–30%.
Specific microbiology here, similar to elsewhere.
Source notes Staph aureus is commonest in early infections here. Coagulase-negative staph, like Staph epidermidis, predominates in late-onset infections.
And specific diagnostic tools for the SAT.
General workflow applies. Ultrasound is useful initially, especially for superficial carotids, checks patency, collections. Source notes carotid patch corrugation on ultrasound might be an early warning sign. CTA with cerebral CT is crucial for anatomy, pseudoaneurysm, abscess. If those are inconclusive, FDG-PET-CT or WBCS can confirm infection site extent, especially deeper near the neck base or mediastinum. While surgery is the mainstay, the source briefly mentions conservative treatment.
How successful is conservative management alone here?
Generally high failure rate. Rarely curative alone. Risk of persistent infection, bleeding, stroke is significant if infected material stays.
Any less invasive conservative techniques mentioned?
Yes, the Endovac technique uses VAC principles inside the infected space. proposed as a bridge to surgery for unstable patients, or palliation if no definitive options exist.
The results for Endovac here, strong evidence.
Showed good results in limited selected patients with severe comorbidities or tough anatomy, but source explicitly says this is limited evidence, mostly from one center series.
And the recommendation for Endovac.
Endovac technique may be considered in selected SAT-VGEI patients when neither total removal nor usual conservative VAC are feasible safe. That's recommendation 18, class 2B, level C.
Let's decode. Class 2B usefulness less established may be considered. Level C, expert opinion small series. So an option in specific tough spots, but evidence isn't strong. Moving to the primary approach, surgical treatment. Guiding principles for SAT surgery.
Fundamental principle. Total explantation, complete removal of the infected graft or patch in the elective setting whenever possible.
Reconstruction needed after explant, or just tie off.
Reconstruction is usually mandatory, especially for carotids, to avoid stroke. Primary ligation, tying off, might be considered only in dire emergencies, EOG, if infected graft is already thrombosed without neurosymptoms, or patient has completed stroke and revascularization is too risky. Reperfusion injury. It's damage control to stop bleeding when reconstruction isn't safe feasible immediately.
So, reconstruct usually, unless emergency ligation is life-saving, preferred reconstruction graft material for infected SAT.
Autologous material first line. Since reconstructions here are often short, autologous saphenous vein, as bypasser patch, is often feasible and preferred. Good results reported using saphenous vein, benefiting from its infection resistance.
Saphenous vein is the workhorse. Surgical approach always partial or total explantation.
Total surgical approach, complete removal, is recommended electively. Achieving this might need complex approaches, sternotomy, clamshell depending on location near the arch. These give better access for safe debridement and control. Proximal arterial control is critical, especially with active bleeding. Trying to get control through the infected neck incision is risky blood loss, nerve injury, recurrent laryngeal, hypoglossal. Partial explantation, less invasive, may be considered in selected high-risk patients if material is well incorporated with limited infection signs, but associated with higher reinfection risk than total removal.
Specific techniques mentioned for managing vessels after explant.
Things like carotid stump closure, venous patch angioplasty using vein, interposition bypasses using saphenous vein or other autologous conduits.
Any adjunctive therapy recommended during SAT repair?
Yes, covering the repair with local biological material is recommended. Specifically, covering with local muscle flaps like a sternocleidomastoid flap from the neck is recommended. Reinforces suture lines, brings vascularized tissue, fills dead space.
Finally, follow-up and prognosis for SAT infections.
Prognosis remains challenging. High rates of neuroevents, mortality up to 25–30%. Reinfection is a significant risk. Source cites a review of 57 studies, 103 patients. Treatments varied, conservative, veins, other conduits. High periop complication rate, 54.6%. Median follow-up short, 4.5 months, 5 related deaths. Figure 4 summarizes this grim reality.
That study really shows the morbidity. Specific recommendation for emergency bleeding.
Yes. In emergency active bleeding with SAT-VGEI, proximal arterial control and graft excision is recommended. That's recommendation 19, class 1, level C.
Class 1 is recommended as necessary in emergency. Level C, based on expert opinion surgical principles for critical emergencies, not comparative trials. Get control. Get infected source out top priority. Mega recap. We dove into super aortic trunk SAT infections, low incidence, high mortality morbidity, staph aureus common early, coag-neg staph late, diagnostics, US CTA nuclear imaging, conservative treatment fails often, Endovac class 2B level C may be considered selectively, mainstay is surgical explantation, total preferred, with autologous vein reconstruction, proximal control vital in emergencies, class 1 level C rec for control plus excision, adjunctive muscle flaps recommended, prognosis challenging, micro recap. Key SAT surgical principles, explant infected imperial, reconstruct with autologous vein, proximal control vital in emergencies, class 1 level C, local muscle flap cover recommended, #tag 6, thoracic thoraco-abdominal aorta. Moving down to the thoracic and thoraco-abdominal aorta, arguably the most complex and dangerous VGEIs.
Absolutely. Infections here are incredibly challenging due to anatomy, high flow, proximity to vital structures.
Incidents here, outcomes.
Incidence reported up to 6% in some series, especially complex procedures. Mortality is very high when infection occurs, sometimes up to 75%, depending heavily on presentation and complications like fistulae. And with more thoracic endovascular aneurysm repair, TEVAR procedures, the incidence is unfortunately rising.
And these are often complicated by fistulae.
Yes, a major complicating factor is frequent association with fistulae abnormal connections. Aortoesophageal fistula, AESF to the esophagus, aortobronchial, ABF to airway, aortopulmonary, APF to lung pulmonary artery. These cause devastating bleeding, introduce more contamination, complicate treatment hugely, needing extra surgery to fix the non-aortic defect. A systematic review cited found 233 thoracic VGEI patients, 49 open graft, 184 endograft. In large TIVR registries, AESF incidence was 1.5–1.7%. That review found AEF association significantly more frequent with endografts versus open grafts, 60% versus 31%, and time to infection significantly shorter with endografts, means 17 versus 32 months.
Just endografts might be more prone to fistulae here and earlier. Typical clinical presentation for thoracic thoracoabdominal infections.
Highly variable. Can be subtle unexplained fever, maybe mimicking post-implantation syndrome, or severe overt sepsis, massive bleeding if fistula, shock.
Local signs in chest, upper abdomen.
Mostly absent due to deep location. Systemic signs, fever, high WBC, CRP, more common. Septic emboli can cause distant infections, abscesses. If fistula present, AES, FABF, first symptom might be bleeding, hematemesis, vomiting blood, or hemoptysis, coughing blood, often preceded by self-limiting herald bleeding hours or days before catastrophic bleed. Recognizing herald bleed is critical.
That herald bleed, a crucial warning sign. Specific diagnostic modalities for this complex region.
Definite diagnosis usually needs high-quality cross-sectional imaging. CTA is typically initial test shows paragraph fluid, late air abscess. If CTA is inconclusive but suspicion low-grade, FDG-PET-CT should be done highly sensitive. If AESF suspected, esophagoscopy might directly show graft protruding. For ABF, bronchoscopy might show defect if central, AG left main bronchus. Generally, tailored diagnostic tests, CT, CTA, MRI, PT-CT, endoscopy, bronchoscopy, to the specific suspected complication.
Micro recap. We started on thoracoabdominal VGEI. High incidence mortality, rising with TIVR. Frequent dangerous fistula complications, AESF, ABF. Potentially more common earlier with endografts. Varied presentation, often lacks local signs, can range from fever to sepsis or critical bleeding. Hematemesis hemoptysis, often preceded by herald bleed. Diagnostics rely on CTA, targeted PET-CT, endoscopy, bronchoscopy for fistulae. Let's break down treatment for thoracic infections, starting without fistula. Surgical principles here.
Fundamental principles: control sepsis, remove infected material, reconstruct in clean field. But this ideal is often unachievable in these very sick patients with complex anatomy. So as Figure 5 algorithm shows, staged repair or conservative treatment might be the only option sometimes.
So ideal, often not possible. What does conservative treatment involve for non-fistulous thoracic VGEI?
While not curative alone for graft infection, conservative measures can help manage collections or reduce bacterial load. Percutaneous drainage for collections abscesses under USCT guidance. Pigtail catheter left until drained, combined with antibiotics, reduces local bacterial burden. Also, irrigation of the space-drained collection with saline or antiseptic solution mechanically dilutes bacteria, but source notes unresolved issue. No strong evidence on the best antiseptic solution choice.
Moving to surgical treatment for non-fistulous thoracic infections. Preferred definitive approach for fit patients.
For fit patients where anatomy allows, in situ reconstruction, ISR, replacing infected graft with new conduit in original position is generally recommended. Requires aggressive surgical debridement, creating clean field, then reconstruction with infection-resistant material.
Specific techniques for ISR in this hugely complex region.
Technique depends heavily on location extent. Arch involvement might need median sternotomy or clamshell incision, cardiopulmonary bypass, circulatory arrest, selective cerebral perfusion. Extensive thoracoabdominal repairs might need CSF drainage, pre-op, intra-op evoked potential monitoring for spinal cord protection. If near left subclavian artery and clamping isn't safe, hypothermic circulatory arrest might be needed. Thoracoabdominal exposure, usually via thoracofrenal laparotomy. Techniques to protect visceral renal arteries during cross-clamping used.
Perfusion.
Underscores the massive scale. What graft materials for ISR in this infected field?
Several options. Cryopreserved aortic allografts, human donor aorta, biological thought more infection-resistant than synthetic, risk of late degeneration, aneurysm rupture, variable reinfection rates. Treated polyethylene terephthalate, PET grafts, most of standard PET, 12%. Results likely extrapolated to TIVR setting. Bovine pericardium, xenograft. Tailored tube from sheets. Promoted in case series, needs more study, longer follow-up.
Any adjunctive therapy recommended during thoracic thoracoabdominal ISR?
Yes, covering the new graft with biological material is recommended. Crucial to separate graft from contaminated tissues, fill dead space. Omentum preferred. rich vascularity, immune properties. Prepared, routed through diaphragm to cover graft. More extensive options: latissimus dorsi, serratus muscle flaps. If no viable tissue, bovine pericardial patch suggested.
What about extra anatomic reconstruction?
Yeah.
ER, bypassing infected area. Used here.
Yes, ER is an alternative strategy to avoid reconstructing in the infected field. Create bypass outside infected zone, then ligate aorta and remove infected graft. Often staged. Technique: restore distal flow after aortic ligation. Axillobifemoral bypass, common infradiaphragmatically, but might not perfuse visceral organs well retrogradely. Most common ER for thoracic is the ventral aorta retrosternal graft from ascending aorta to supracoeliac abdominal aorta or distal. Often staged, bypass first, then remove infected graft.
Yeah.
Limitations: acute bleeding, arch involvement, alternative routes, posterior pericardial, subcutaneous, intrathoracic.
Management outcomes for thoracic VGEI.
Reflect the high risk. Surgical mortality high, up to 50–60% in some series. Staged repair might have slightly lower mortality than single stage in some reports. Reinfection still occurs after ER. Systematic review: 134 thoracic VGEI patients. Overall, 5-year survival low, 4G 24% after ER plus excision. ISR with allograft showed better long-term survival, 53% at 5 year versus ER, 21%. Survival better after open graft versus endograft infection, better after abdominal versus thoracic thoraco-abdominal. Strategy needs high individualization based on patient anatomy center expertise.
Mega recap. We covered thoracic thoraabdominal VGEI management. High incidence mortality, rising with TEVAR, often complicated by fistulae, AEs F, EBF. Varied presentation, fever to sepsis bleeding, watch for Herald bleed. Diagnostics, CTA plus PET-CT. Endoscopy bronchoscopy for fistulae, for non-fistulous. Conservative drainage irrigation adjunctively. Surgery, ISR preferred if feasible, uses infection-resistant materials, allograft, treated peat, bovine pericardium, with crucial biological coverage, omentum. ER is alternative, ventral aorta common. High mortality, outcomes vary, strategy highly individualized. Micro recap. Key points for non-fistulous thoracic VGEI. ISR with infection-resistant graft plus omental cover preferred if feasible. ER is alternative. Conservative options are adjuncts, not cures. Now the even more complex scenario. Fistula complicating thoracic VGEI. First, aortoesophageal fistula, AESF.
Almost invariably fatal. Source mentions one anecdotal case surviving conservatively, but that's an extreme exception. Definitive intervention is needed.
Endovascular treatment role. Placing an endograft for bleeding, AESF.
In acute life-threatening bleeding, emergency endograft insertion may be proposed to control bleeding, stabilize hemodynamics, often called a stopgap or bridge treatment. But major limitations alone, doesn't remove infected material, doesn't close esophageal defect, should be seen mainly as a bridge to definitive open surgery, not a standalone solution. Study findings confirm limitations. National survey, high 30 mortality, 28%, overall mortality, 44% at 23 OMO, high reintervention rate, 28%, with high mortality, 60%. TEVAR plus esophageal bronchial repair had lower mortality than TEVAR alone, 30% was 55%. UREC registry also showed significant survival benefit for radical open surgery versus any other strategy for AESF after TEVAR. Patients getting TEVAR initially who couldn't have later open repair had worse prognosis, mortality near 100%.
Message is clear. TEVAR is a life-saving bridge for AESF bleeding, but not a cure.
Precisely. Definitive open surgery must be performed once stable to remove infected material, close esophageal defect, ensure durable results.
Specific recommendations for managing AESF with thoracic VGEI.
For fit patients, explantation of infected material, repair of esophagus, coverage with viable tissue is recommended as definitive treatment. That's recommendation 29, class 1, level B.
Class 1 is recommended. Level B, single RCT or large non-randomized studies like registry data. So radical open surgery is recommended definitive approach for fit patients.
And for emergency bleeding, initial endograft treatment as a bridge to definitive treatment should be considered. That's recommendation 30, class 2A, level B.
Class 2A should be considered. Level B evidence likely shows bleeding control, so endograft recommended as temporary bridge in emergency.
Also a strong negative recommendation. Treatment with an esophageal endoprosthesis stent alone is not recommended. That's recommendation 32, class 3, level C.
Class 3, not recommended. Level C, expert opinion, small studies likely show failure. Esophageal stenting is not the answer.
The source details treatment of the esophagus itself during definitive repair. Both aorta and esophagus need addressing. Esophageal closure essential to prevent persistent infection mediastinitis. Methylene blue helps locate small lesions. If limited defect, good tissue. Primary double-layer suture repair, reinforced covered by flap, pericardial intercostal muscle. High risk of leak, Most authors agree limited repair has limited place, usually lesion too large or wall quality poor. Radical option, esophagectomy, remove partal, done concurrently or staged, restore continuity later, gastric pull-up, colonic interposition, high morbidity mortality, long recovery. Staged bridge treatment, emergency endo-exclusion plus staged open repair of esophagus bronchus plus graft removal plus flap, showed promise in small series, 87.5% survival at 34 Fushimo, no rebleed in 8 patients. Regardless, patients need intensive medical nutritional support pre-op.
Moving to aortobronchial fistula, ABF, aortopulmonary fistula, APF. Management compared to AESF.
Also typically present with bleeding, hemoptysis. Emergency TAVR for ABF reported high short-term success, 93.2%, low 30 no mortality, 5.9%. But like AESF, doesn't fix underlying infection or airway defect. Aortic-related mortality, 14.3% at 17 Como, and ABF recurrence, 11.1% persist. TAVR alone, higher mortality than TAVR plus repair. Meta-analysis found AESF patients often worse off initially, shock sepsis, than ABF after TAVR, suggesting separate considerations post-bridge.
Open surgical treatment for ABF-APF.
Still first choice for fit patients. Operative mortality, 15 to 41%. UREX registry showed radical surgical approach gave significantly better survival, 63% at 2YR versus other strategies. Technique involves repairing bronchial defect, primary closure flap or pulmonary resection if large. Infected material must be removed. For fit patients, endograft removal plus in situ vascular repair should be considered.
Guideline recommendation for managing ABF-APF with thoracic VGUI.
Closure of airway defect plus explantation of infected material plus in situ reconstruction should be considered as definitive treatment. That's recommendation 33, class 2A, level C.
Class 2A should be considered. Level C. Expert opinion, small studies. Rare key complexity. Expert consensus supports addressing both airway and graft with ISR for fit patients. Wrapping up thoracic, follow-up, and prognosis after treatment.
Overall, midterm mortality varies widely, 14.3% to 75%. Depends heavily on presentation, condition, treatment. Presence of ACES-ABF is a worsening prognostic factor. Follow-up crucial. Monitor inflammatory markers, repeat imaging, CTA plus MISHI-CT. Lifelong surveillance often needed, especially if infected material not fully removed or even after definitive repair.
Mega recap. We covered complex thoracic thoraco-abdominal VGEI. High incidence mortality rising with TAVR, often with fistulae. AESF-ABF, varied presentation, fever to sepsis, bleeding, hair will bleed, non-fistulous, conservative draining irrigation adjunctively. Surgery, ISR preferred if feasible, uses infection-resistant grafts plus omental cover, ear alternative. For devastating fistulae, AESF-ABF. Endograft is bridge for emergency bleeding, class 2A level B, but definitive open repair of both aortograft, explant plus MASH ISR, and esophagus airway is crucial for fit patients. Class 1 level B for AESF, Class 2A level C for ABF-APF. High risk, individualized strategy, lifelong follow-up needed. Micro recap. Key points for thoracic fistulae. Endografts are temporary bridges for bleeding. Definitive open repair of both defects is needed for fit patients. Class 1B for AESF, Class 2AC for ABA-APF. Yes, while maybe less complex surgically than thoracic, abdominal aortic infections are seen more frequently after both open and endovascular repairs.
Incidence after open AAA repair versus EV.
Incidence after open AAA varies, typically 0.2% to 5%. After EVR, generally lower, 1%, though some registries show higher numbers long-term or after re-interventions. Aortoenteric fistula, AENF, is a major severe complication here in 1–2% overall. One registry of infected stent grafts found AENF in 23.9%. EVR done after a previous anastomotic pseudoaneurysm was significantly linked to later AENF.
Highlights AENF as a big concern. Typical clinical presentation of abdominal aortic infections.
Varied. Most 70% have pain, abdominal back, fever, leukocytosis. About a third have nonspecific symptoms. Weight loss, fatigue, weakness. For AENF specifically, bleeding is most common, 71.7% in one review. Then sepsis, 39.7%. Hemorrhagic shock, 33.1%.
So pain, fever, common, but bleeding is the hallmark of AENF. Specific diagnostic modalities for abdominal VGEI, especially suspected AENF.
If AENF or GI bleed suspected, upper endoscopy, gastroduodenoscopy, and/or colonoscopy indicated to look for fistula. Microbiology, polymicrobial infections, gram-neg plus PAS, common in AENF due to bowel flora. Imaging general workflow applies CTA first, then nuclear, PET-CT or WBCS-SPECT-CT if CTA non-convincing, figure 2.
All right, treatment options for abdominal aortic infections. General approach, is conservative ever enough?
Aggressive management required. Graft rupture precludes conservative approach. As standalone definitive treatment, Conservative management for abdominal aortic VGEI is hardly ever possible or successful. Associated with 100% 30-lateral mortality in small series, persistent sepsis, rupture.
So very limited role alone. What conservative measures might be used adjunctively or as a bridge?
Percutaneous drainage of collections abscesses near abdominal graft may be possible. Minimally invasive reduces bacterial load, gets samples. Image-guided pigtail drain, maybe irrigation. Can do sonography via drain to rule out fistula, but crucial point. Even with drainage plus antibiotics for infrarenal VGEI, 40% 30% mortality reported. Drainage alone is not curative for the graft infection.
Highlights drainage isn't the cure. Recommendation on percutaneous drainage.
Percutaneous drainage plus irrigation may be considered for micro-ID and reducing bacterial burden, but not as ultimate treatment in abdominal aortic VGEI. That's recommendation 37, class 2B, level C.
Class 2B. Usefulness, less established as definitive therapy, may be considered as supporting measure. Level C, expert opinion, small studies. An adjunct, not definitive treatment. Leads to surgical treatment. The definitive approach for fit patients. Cornerstone of surgery here.
For fit patients, complete excision of all infected graft material and associated infected tissue is recommended as definitive treatment. That's recommendation 38, class 1, level B.
Class 1 is recommended as beneficial, effective, definitive treatment. Level B, single large RCT or large non-randomized studies support surgical explantation. Getting infected foreign body out is fundamental.
Yes, explantation is key. Then restore vascular continuity. In situ reconstruction, ISR, new graft in original position after debridement, often primary choice. Needs extensive debridement, reconstruction with infection-resistant material, and clean Borgel field.
What graft materials for ISR and abdominal aorta?
Several options. Autologous vein, often preferred. Deep femoral, superficial femoral veins, or composite bilateral great saphenous veins, GSV, advantages, patient's own tissue, infection-resistant biological incorporation. Disadvantages: donor site surgery morbidity, CVI up to 15%, DVT up to 22%, limited availability sometimes prior DVT, maybe less effective versus MDR gram-neg MRSA candida, but meta-regression preferred veins, especially younger patients, even with AENF or virulent organisms, giving best outcomes there, particularly preferred in younger patients with longer life expectancy.
So autologous vein often preferred biological option despite donor issues. What about cryopreserved allografts?
Another biological option, human donor aortaliac. Advantages: off-the-shelf, size match, relatively infection-resistant. Disadvantages: risk of late degeneration, annulus rupture, variable availability quality, need specific storage, variable reinfection rates, mixed results on long-term degeneration risk. No evidence immunosuppression helps.
Lifelong surveillance needed with allografts.
Yes, absolutely. Lifelong imaging follow-up is recommended after ISR with cryopreserved allografts for abdominal VGEI, crucial to detect late degeneration-urism. That's recommendation 43, class 1, level C.
Class 1 is recommended for monitoring. Level C, expert opinion based on known risk. Monitor allografts closely for life.
Next, modified synthetics. Rifampicin-bonded grafts, PEE impregnated with rifampicin, can consider for less virulent, low-grade infections, especially staph. Advantage: readily available synthetic. Disadvantage: 11.5%, weak versus non-fermenter gram-negs, Pseudomonas. Less effective versus MRS, other gram-negs candida. Efficacy depends on bug susceptibility and low bacterial load, no bowel injury. Silver-coated grafts, PET or EPTFE with silver coating. Advantage: broad-spectrum antimicrobial. Disadvantage: uncertain long-term silver release efficacy, variable evidence, reinfection 0, tax 16%, no comparison between silver coatings, limited data specifically in aortoiliac position for infection. Finally, xenogenous grafts, animal tissue, bovine prosthesis, trend to low infection rates in small series, no recommendation possible yet.
Comprehensive rundown of ISR graft options. Sounds like autologous vein often preferred, especially young virulent bugs. Allografts, viable biological option, needs lifelong monitoring. Modified synthetics may be in specific lower virulence cases. Any adjunctive therapies during abdominal ISR?
Yes, similar to thoracic, covering the new graft with biological material is recommended. Crucial adjunct. Separates new graft from contaminated tissues, fills dead space. Preferred. Pedicle omentum flap, or muscle, fascia, retroperitoneal tissue. Omental wrap lowers reinfection even with rifampicin silver grafts, strongest predictor of survival. Insufficient data on local antibiotic bead sponges here, mostly extracavity use. NPWT described in few cases via retroperitoneal approach. Foam on graft needs repeat changes, no long-term data.
What about extra anatomic reconstruction, EAR, in abdominal aorta? Still an option.
Yes, EAR is alternative to ISR. bypasses through clean field, or axillobifemoral axillobipopliteal, then excise infected graft. Advantage: avoids reconstructing an infected field. Disadvantages: significant. Lower long-term patency, 64-75% at 5 back there. Higher amputation rate, up to 11% at 5 bare. Major risk: proximal aortic sump rupture, up to 27%. Reinfection of bypass itself, 0-27%. High mortality, 30-18%. Late, 32%.
Given those downsides, when might EAR be considered for abdominal VGEI?
For patients with abdominal VGEI plus large abscess or multi-resistant bugs where ISR success less likely, ER may be considered. That's recommendation 42, Class 2B, Level B.
Class 2B usefulness less established versus ISR may be considered. Level B based on single large RCT or non-randomized study data. An option for severe complex cases, but not preferred generally due to risks like stump rupture. What about endovascular treatment with endograft for existing abdominal VGEI? Relining.
Generally not considered definitive treatment. Primary role limited to temporary measure bridge to open repair, especially in emergency bleeding, AENF, or very high-risk patients unfit for immediate open surgery. Outcomes poor if used definitively. High reinfection up to 63%. High mortality up to 63.3% at 30 even with antibiotics. Stump issues possible after removing original graft if suprarenal hooks used.
So not definitive. Recommendation for endografts here.
In acute active bleeding complicating abdominal VGEI plus AENF, initial treatment with endograft should be considered, but only as a temporary measure. That's recommendation 45, Class 2A, Level C.
Class 2 should be considered for temporary control. Level C, expert opinion, small studies likely show bleeding control efficacy. Recommended temporizing measure in bleeding emergency. Goal remains definitive open repair if possible. Micro recap. We covered abdominal VGEI management, high incidence, risk of AENF, conservative treatment, rarely effective alone, drainage adjunct, Class 2B, Level C, cornerstone for fit patients, complete explantation, Class 1, Level B, plus ISR primarily, ISR grafts, autologous vein preferred biological, allografts need lifelong surveillance, Class 1, Level C, modified synthetics, selective use, crucial adjunctive omentoplasty improves survival, Class 1, Level B. ER alternative for severe resistant cases, Class 2B, Level B, and a treat bridge only in bleeding emergencies, Class 2A, Level C, not definitive. Let's specifically address graft enteric fistula, AENF, a particularly challenging complication in the abdomen.
A direct communication between prosthesis and bowel, usually duodenum, can occur early technical issue or late pseudoaneurysm erosion graft infection spread.
Specific treatment modalities and critical steps when AENF is present.
Need to address both vascular and bowel. Secure proximal aortic control, supraceliac approach may be needed. Bowel repair, critical. Avoid simple suture if possible, high breakdown risk. Options: primary repair, small defects, good tissue, double layer suture, buttress, or segment resection, plus primary anastomosis, temporary diversion, colostomy. Infected graft must be excised completely. Vascular reconstruction follows. ISR or EAR.
Definitive consensus on ISR versus EAR for AENF outcomes.
Ongoing controversy. Systematic review cited suggested staged AXFEM bypass plus graft removal, EIR, was best. Mortality 31% non-stage, 47% ISR. Found no reinfection difference, but mostly used standard PET-CT grafts. This contrasts with other studies finding ISR as biological plus debridement improves survival. Highlights debate, lack of definitive RCTs, need for individualized decisions. Despite controversy over ISR versus EAR, strong recommendation on adjunctive therapy for AENF.
Which crucial adjunctive step is strongly recommended with AENF?
Transfer of autologous vascularized tissue, omentum preferred or muscle flap, to cover vascular reconstruction and separate from bowel repair is recommended when feasible. Omentoplasty flap wrap shown to lower reinfection, strongest predictor of survival with AENF. That's recommendation 46, Class 1, Level B.
Class 1 is recommended. Level B evidence, cohorts registries, shows survival benefit. Regardless of ISR, cover new graft with vascularized tissue omentum if AENF presents crucial for survival.
Briefly, other specific rare complications fistulae mentioned.
Yes. Infections of visceral artery revascularization bypass is rare. Treatment evolving. Endo first to recanalize native vessel, then remove infected graft. Close anastomosis with vein patch. Also arterioureteral fistula, AUF, rare, 1%. Usually after prior urinary tract procedure stone injury during aortic surgery. Presence with bleeding, hematuria, or urosepsis.
Recommendations for managing AUF with abdominal VGEI.
Emergency bleeding. Initial endograft treatment may be considered only as temporary measure. That's recommendation 47, Class 2B, Level C.
Class 2B may be considered. Level C, expert opinion, small studies, bleeding control. Temporary bridge only. Definitive AUF management. Complete graft explantation plus urological treatment. Repair, reimplant, nephrostomy, nephrectomy. Plus in situ arterial reconstruction should be considered. That's recommendation 48, class 2A, level C.
Class 2A should be considered level C. Expert opinion small studies, definitive, remove graft, fix ureter with urology, reconstruct artery, often ISR.
Overall outcomes and influencing factors for abdominal VGEI. Outcomes variable. Patient factors, infection type, treatment, center experience, lack of comparative studies, selection bias, individual decisions needed, MDT crucial, factors linked to higher mortality, poor patient condition, ASA4 sepsis, emergency setting, AENF presence, virulent MRS-MER organisms. Variable antibiotic duration specimens make study comparison hard.
Post-treatment follow-up needed.
Yes, important. Close surveillance. Clinical labs U.S. every 3-6 mo for min 1 hour, then lifelong every 6-12 mo reasonable. CT, it's suspicious. Special attention after ISR with allografts, degeneration risks. Unfit patients on conservative lifelong antibiotics need irregular imaging, US CT.
The guidelines consolidate this into a proposed algorithm, figure 6. Can you walk us through it?
Starts with suspected abdominal VGEO. First question. Acute bleeding. Yes. Emergency. Next, fit for surgery. Yes. Surgical management. Explant plus vascular reconstruction. ISR first choice list materials. Allograft, treated PE, xenograft, or ER. Omentoplasty recommended. Bowel repair of AENF. Prolonged antibiotics, long-term follow-up. If acute bleeding but not fit for surgery, consider bridge treatment with Endograft, Rec 45. Reassess fitness, still unfit. Conservative palliative path, back to start, no acute bleeding. Next question. Aortoenteric fistula. Yes, cracked explantation needed. Assess fitness for surgery. Follow yes/no path as above. Is no acute bleeding and D no fistula? Graft explantation still primary step. Then vascular reconstruction, ISR first choice or ER. Omentoplasty, prolonged antibiotics, long-term follow-up. Alternative route from here, conservative palliative, antibiotics, drainage, irrigation. Also suggests endograft might be considered here. If limited infection signs plus high operative risk, this path also needs prolonged antibiotics, long-term follow-up.
Mega recap. We covered abdominal aortic VGEI. Common dislocation, AENF, risk significant. Conservative treatment, rarely effective alone. Drainage adjunct, class 2B, level C. Cornerstone for fit patients. Complete explantation, class 1, level B, plus ISR primarily. ISR grafts, autologous vein preferred. Allografts need lifelong surveillance, class 1, level C. Modified synthetic selective use. Crucial adjunctive omentoplasty improves survival, class 1, level B, especially with AENF. ER alternative for severe existing cases, class 2B, level B. Endotreatment bridge only in bleeding emergencies, class 2A, level C, not definitive. Covered AUF management. Outcomes variable, lifelong follow-up needed. Walk through management algorithm, figure 6. Micro recap. Key abdominal ISR graft options. Autologous vein preferred biological. Allografts need lifelong monitoring. Modified synthetics selective use. Adjunctive omentoplasty crucial, class 1B, hashtag TIC-TIG8, peripheral arteries, final area. Infections involving peripheral arteries, often related to wound issues, especially groin.
Yes, peripheral VGEI, especially lower limb, not uncommon, can lead to limb loss.
Incidence in peripheral bypasses, key risk factors.
Incidence varies by location. Up to 2.5% FemFem, up to 2.8% FemPop prosthetic bypasses, higher 18% in series involving femoral artery after major amputation or early re-intervention. Risk highest if amputation 4 weeks after bypass. Distinction between deep wound infection and true VGEI can be unclear in older reports. Surgical site infection, SSI, is strongest risk factor for peripheral VGEI. While the general SSI risk factors matter, source notes they don't strictly correlate with VGEI in all cases, suggesting direct contamination or wound complications are likely key pathway.
Examples of patient-related risk factors for lower limb SSIs from Table 12 helps identify higher-risk patients.
Table 12 lists several. Female sex, or 1.34, obesity, or 2.91, BMI 25, or 1.78, COPD, or 4.29, dialysis, or 2.1 or 4.20, major amputation, or 2.91, high blood glucose 11, or DIRC, or 2.68, show systemic health and local factors raise SSI risk.
Helpful list for pre-op assessment optimization. Infections of peripheral stents, common.
Rare, 1%. Emergency procedures with adjunctive thrombolysis considered risk factors.
Typical clinical presentation of peripheral VGEI.
Groin involvement, common access site. May see draining sinus, exposed graft, swelling, pain, redness, plus summoned fever. Serious signs. Pseudoaneurysm, active bleeding, limb life threat. Sepsis.
Specific diagnostic modalities peripherally.
General workflow. US CTA, FDG-PET-CT, WBCS-SPECT-CT used based on suspicion availability. US good first look superficially. CTA shows anatomy. As discussed, WBCS-SPECT-CT specifically recommended Class 1 Level B as additional imaging for peripheral VGEI if initial CTA non-convincing, Rec 10.
Micro recap. Started on peripheral VGEI. Variable incidence, strong link to SSI.
Yeah.
Key patient SSI risk factors identified, obesity, CLI, diabetes, etc. Presentation, often groin wound issues, sinus, exposed graft, risk of bleeding, pseudoaneurysm. Diagnostics, US, CTA nuclear, WBCS-SPECT-CT recommended class 1B if CTA equivocal peripherally. Now, there are treatment options for peripheral VGEI. Conservative treatment alone sufficient.
Rarely definitive option for lower limb VGEI without removing graft. High mortality, up to 45% at 5-year. Persistent infection, anastomotic disruption risk if graft left.
So, not sufficient alone. Conservative measures used adjunctively or as bridge.
Negative pressure wound therapy, and PWT, useful for complex wounds, ESPA groinor. Promotes healing, reduces bacterial load, can allow graft visualization. Used as bridge or potentially definitive part if patient unfit for reconstruction with lifelong antibiotics. Needs expertise near exposed graft synastomosis, bleeding risk. Requires multiple dressing changes.
Moving to surgical treatment, generally needed. Core principles.
Radical surgical debridement, removal of infected material. Reconstruction choice, ISR versus EAR, depends on location, infection extent, graft material, tissue viability, patient condition. ISR preferred if technically feasible in relatively clean debrided field.
Graft materials for peripheral ISR.
Several options. Autologous vein preferred conduit, great saphenous vein, high infection resistance, patency lower below knee, but still preferred in infected fields. Prosthetic grafts, TFE, readily available, shorter op time. High reinfection versus non-prosthetic. Silver impregnated or rifampicin-soaked PAT used, but low evidence level peripherally, mostly aortic data. One study, 24 FemPop ISR with silver grafts, 19% reinfection. Rifampicin efficacy depends on bug sensitivity, less effective versus gram-negs. Xenogenous grafts, bovine pericardial patches, can replace infected patches-close defects, supposedly more infection resistant. One series, 51 bovine patches after infected EPTFE patch removal, one rupture, no other infection complications.
What about adjunctive therapy during peripheral repair, especially for complex groin wounds?
Growing evidence suggests muscle flap coverage in addition to graft removal plus reconstruction is highly effective for complex infected groin wounds. May improve graft limb salvage, survival. Retrospective studies support use in high-risk patients, decrease groin wound morbidity. More data needed on ideal flap type.
Specific muscle flaps commonly used for groin coverage.
Several described. Sartorius muscle flap, SMF. Standard technique. Blood supply concerns if SFA occluded, but usually okay if deep femoral artery PFA patent. Compromised if PFA occluded. Low reintervention rate, 4.1%, 30 pen in one series. No difference versus RFF in one study. Rectus femoris flap, RFF. Easy harvest, robust blood supply, excellent rotation bulk for defects. Smaller donor site morbidity possible. No significant difference versus SMF in complication salvage in one study. Gracilis muscle flap, GMF, medial thigh. High healing rate reported for complex infected groin wounds, even with synthetic graft. Technically easy. Prospective study, 22 patients, 45% graft infection, 100% healing at 3 probuloma with GMF plus MPWT plus lifelong antibiotics. Rectus abdominis flap, RAF, abdomen, for very large defects where groin closure impossible. Excellent coverage, reliable anatomy, high success but significant donor site problems, hernia, pain. Also, antibiotic-loaded beads, PMMA with Vancturge, placed in dead space after debridement, often with flap, high local antibiotic concentration. Can allow healing, but reinfection up to 20% reported.
Comprehensive options for adjunctive coverage, highlighting wound management importance, especially groin. What about extra anatomic reconstruction, EAR, peripherally?
Used to bypass infected field, example, obturator bypass, OB. Tunnels through obturator canal, medial to groin, for FemPop, aortofem infections limited to femoral area. Conduit, same preferred, PTFE. Outcomes variable, one series, 18 OBs for infected femoral grafts. 6% infection, high secondary patency, 88% 2YR, high limb salvage, 89%, but high reintervention, 61%. Femoral artery reconstruction, limited reconstruction, maybe in selected cases of suprainguinal grafts incorporated, infection localized. Small series suggests low reinfection with silver allograft main interposition, limited evidence. Lateral femoral bypass, recent technique, tunnels laterally away from infected medial groin, iliac inflow to PFS for distally. Conduits, vein, allograft, rifampicin PET, EPTFE, one series, 16 patients, 10 for infection. High two-cellular assisted patency, 83%, limb salvage, 93.9%. If standard popliteal crural access impossible due to infection, Bypasses to perigeniculate arteries, PGAs, around knee may be useful. Series reported mortality 8.5%, amputation 21.3%, 3-year secondary patency 83%, limb salvage 74%. Also lateral approach to crural arteries, LACA.
Simple solution for threatened limb in difficult situations. Ideal for vein grafts to anterior tibial distal peroneal via lateral tunnel away from infection. Acceptable patency, 1 series, 21 patients, 10 for infection. 1 eye primary patency, 61%.
Broad spectrum of complex surgical options. What about endovascular treatment peripherally? Stent grafts.
Very limited role. Endograft placement in infected peripheral arteries has high reinfection risk if infected material not removed. Primary role strictly limited to temporary bridge and emergencies, for example, bleeding pseudoaneurysm, before definitive open repair. Outcomes consistently poor if used definitively without removing infected graft. High reinfection, 66-100%. Worse outcomes versus open surgery with explantation.
Given poor outcomes, the recommendation for endo treatment peripherally.
Endovascular treatment of peripheral VGEI is not recommended as definitive treatment. That's recommendation 50, class 3, level C.
Class 3. Not recommended as definitive. Level C. Expert opinion small studies show poor outcomes. Very clear guidance against endo as final treatment peripherally.
Including peripheral section, follow-up and prognosis, always serious condition, high-risk amputation reinfection of prosthetic not completely removed. Surveillance needed, underlying disease plus exclude reinfection, sped up incomplete resection. Few reports on optimal protocol. Close surveillance until no infection signs, then maybe annual visits, labs, CT. Outcomes data, 13% major limb amputation within 30 in 1 series. Another study, femoral VGEI, 12% reinfection, 86.5% long-term limb salvage. Shows limb salvage often achievable with appropriate management. Unfit patients on conservative lifelong antibiotics need regular imaging, USCT.
Mega recap. We covered peripheral VGEI. Incidence varies, strong link to SSI. Conservative treatment rarely definitive. NPWT adjunct bridge. Mainstay surgery, radical debridement plus explant, ISR with autologous vein preferred. Ear options, obturator, lateral femoral, PGA, LACA, bypass infected field, adjunctive muscle flaps crucial for groin wounds. Endo treatment not recommended definitively, class 3 level C, bridge only in emergency bleeding. Lifelong surveillance needed, risk amputation reinfection. Micro recaps, key peripheral treatment points, radical debridement explant key, autologous vein preferred ISR conduit. Adjunctive muscle flaps vital for groin wounds. Ear bypasses offer alternatives. Endo treatment not definitive. Class 3C. #9. Patients' perspectives. We've gone deep into the technicalities, diagnosis, prevention, complex surgery. But as we noted, these guidelines uniquely included patients' perspectives. Why is this so important in such a technical field?
It's fundamental to patient-centered care. As the source highlights, treatment proposals, especially complex ones, need clear, honest, informed consent. With synthetic implants, infection is a major threat. That risk needs clear explanation before the initial procedure, so patients understand the balance of benefits versus risks, including the serious consequences of infection.
Are there specific aspects of vascular procedures or patients that make this perspective unique or challenging here?
Yes, the source points out a few things. First, pathological presentations. Procedures might be urgent life limb saving, where risk tolerance is higher. Others are for function, claudication, or prevention, aneurysm. Patients might accept risk differently depending on indication. Second, typical patient age and comorbidities, often older, multiple health issues, cardiac, pulmonary, renal, diabetes. Frailty makes secondary interventions for infection harder to tolerate, plus managing complex imaging, contrast. Prolonged antibiotics is tougher for them. Third, the perception of easy endovascular surgery. Patients might see minimally invasive procedures as minor, underestimating potential for serious complications like infection, which can be just as devastating after endo as open surgery, a critical disconnect.
Crucial point, perception mismatch. The guidelines actually interviewed patients. What was the feedback on the first key question? Enough info about infection risk before the initial procedure.
Response was clear. Not enough information provided. Some weren't informed at all. Others told infection was possible, but didn't grasp what VGEI really meant: invasiveness, severity, complexity of management. Patients also noted inconsistencies post-procedure. Some got prophylaxis advice from GPs, others didn't, suggesting lack of primary care awareness. Also noted initial procedures often in general hospitals, re-interventions for infection at university centers. Felt later GP care sometimes lacked advanced knowledge of graft infections.
Insufficient info up front. Inconsistent GP follow-up, confusing transitions.
Oh.
What about the second question? Thoughts on management once VGEI was diagnosed?
Patients generally understood diagnosis was difficult, needed full workup. But major criticism, feeling moved between departments, vascular, ID, radiology, ICU, impaired relationship with the central physician, felt management lacked structure, no clear algorithm followed in their experience, caused uncertainty, feeling lost. This fragmentation was a major source of distress.
That feeling of fragmentation must be incredibly hard. Feedback on the third question, enough info on the risks of VGEI itself once diagnosed.
Patients often unaware of the true complexity and seriousness even after diagnosis. Didn't anticipate the difficulties, pain, tiredness from procedures, prolonged treatment. Key point. Unaware of the close, often lifelong follow-up needed after reintervention. They expected follow-up after initial surgery, but not the intense surveillance burden after infection.
Incredibly insightful, quite moving feedback. Highlights potential shortcomings. Based on this, what specific ways of improvement were suggested?
3 specific recommendations came from the patient feedback. 1. Vascular surgeons must provide more precise, comprehensive information on VGEI risk for all procedures, including endo. Explain precisely what VGEI means regarding invasiveness, consequences, management burden, part of initial consent. 2. Need more education for general practitioners on prophylaxis when to suspect VGEI. Improves early detection, referral, patient confidence post-discharge. Provide precise written info to patients' GPs on needed follow-up screening. 3. Physicians and MBTs need awareness of identifying a referral physician or clear primary contact for the patient. This person provides consistent info on status, evolution, next steps, vital to combat fragmented care feeling.
Mega recap. We explored patient perspectives, key insights, perceived lack of info on infection risk pre-procedure and complexity seriousness post-diagnosis, feeling of fragmented care. Suggestions. Surgeons give more precise VGEI risk info for all procedures. Educate GPs on prophylaxis suspicion. Ensure a clear central point of contact for patient during management. Micro recap. Key patient feedback points. Felt uninformed about risks beforehand, overwhelmed by complexity fragmented care afterward, unaware of lifelong follow-up need. #10 unresolved issues.
To conclude our deep dive, let's look at the final crucial section, unresolved issues, where the writing committee themselves highlight gaps in current knowledge and evidence.
Given the detail covered, surprising there are still substantial gaps.
It is, but reflect the complexity, relative rarity, and research challenges. The committee explicitly acknowledges their review showed a lack of robust evidence in many management aspects. As we noted, evidence quality was mostly retrospective studies, reviews, consensus, most recommendations based on low evidence level, mostly level C.
Why so hard to get higher quality evidence? RCTs, large prospective studies here.
Several reasons. Difficulty comparing populations across studies, variable presentation, microprotocols, imaging, management options, potential publication bias from high-volume centers favoring their techniques. Even meta-analyses must be interpreted cautiously due to heterogeneity of pooled series.
Makes sense. Hard to compare apples and oranges. Given these challenges, what specific areas for research did the committee propose?
They identified several key areas needing investigation. 1. Actual wrist incidence of brain abscesses with supraortic trunk, SAT, VGI. Mentioned risk, but no reliable data to evaluate urgency counsel patients. Refers to Section 5. 2. Formal evaluation of Endovac efficacy for SAT infections. Needs study beyond single team's experience before wider use. Refers to Section 5.2.2. 3. Efficacy outcomes of conservative VGI treatment with drainage irrigation when used primarily, not just adjunctively in unfit patients. Need outcome data. Refers to Sections 5 to 8 conservative parts. 4. Evidence on best antiseptic solutions for irrigation. No strong evidence comparing choices. Refers to irrigation mentions. 5. Robust evidence on efficacy of endografts used as a bridge to definitive repair. Thoracic abdominal. Need data on effectiveness versus immediate stage definitive repair. Refers to endobridge roll, Section 6. 7.
Very specific, clinically relevant questions still unanswered. How do guidelines suggest overcoming challenges to generate this evidence?
Source concludes by reiterating the crucial need, set up large multi-center registries, ideally prospective, with standardized predefined variables, patient characteristics, presentation, microimaging, management, outcomes. This standardized data collection across centers seen as best way to allow valuable comparisons, draw robust conclusions, answer unresolved issues, improve future guidelines and care.
Mega recap. We concluded by looking at unresolved VGEI issues. Key challenge. lack of robust evidence, mostly level C, hard to compare studies, potential bias, need for large prospective multi-center registries stressed, specific research areas proposed, brain abscess risk in S8-VGEI, endovac efficacy, conservative drainage irrigation outcomes, best antiseptics, endograft as bridge efficacy. And that brings us to the end of this deep dive into the ESVS 2020 guidelines on vascular graft and endograft infections. Thank you, our listener, for providing this essential source material. It allowed us to unpack a truly complex, challenging topic.
It's clear managing these infections remains a significant challenge, needing careful diagnosis, intricate multidisciplinary management, highly individualized decisions. These guidelines, despite acknowledged evidence limits, represent current best practice and expert consensus.
Absolutely. And reflecting on both patient perspectives and unresolved issues, here's a final thought for you. Given the lack of robust evidence and patient perception of inadequate information, what steps can you take in practice today? Improve patient understanding of risks complexity during consent for all procedures. Ensure clear communication and a central contact for infected patients. Participate in or establish those crucial prospective registries. Important work needed to bridge gaps in both evidence and patient experience. Thank you for joining us. We hope this thorough exploration provided key insights and clarity on current best practices and future challenges in managing VGEI.
Thank you.
And remember, you can always provide more sources for future deep dives. Until next time.